let me share. Okay. You guys can see my screen, yeah? Okay.
Yes, your screen, we can see it. If you can go for the, yes,
Right.
it's fine.
Okay, great. So before I take the candidates one by one, I'll just take a couple of minutes. I know it will be a teaching viva, but obviously it's the aim is to equip you with the basics of approaching a plain film, particularly regarding bone lesions. But there are basic principles for the exam which will be applicable to any plain film. So I'll just go through it. I always go through it whenever I take viva, so that we can replicate it. I mean, most of you will know it, but I think it's better to just revise it before we start practicing it today. So, I mean, the main aim when a plain film goes in the viva is to find a single salient abnormality, which is usually obvious after you've found it, right? You can't get your eyes away from it. So I think that's very important. I mean, it might be hiding somewhere, but there's usually a salient abnormality that the examiner wants you to detect, describe, and then take on further. And listen to the examiner. When the case goes up, there will be one sentence of important information. It might be the age, it might be the symptoms, it might be the side, or there would be something really a vital clue which will help you kind of stay in line and avoid wasting much time, right? It could be a typical presentation of common kind of pathology, or it could be an unusual location. So I think that's important because that's what they're trying. They're trying to assess your approach and your observation skills, and that you're thorough, the satisfaction of search kind of thing. And always assess review areas and edges of the films, or the last or first or the last slice of your cross-sectional imaging. So I think that's important. And remember another view. I mean, don't ask for it straight away. If you can see something on one view, try to exhaust whatever is there. And before committing, or even after committing, you can say, in my normal practice, I would like to see another view. And obviously, I mean, if you think there is an active process, or you want to see how this, could it be long-standing or something, then there's no harm in asking for previous imaging. And that's what they're after. They want you to replicate your day-to-day clinical practice, that you're a safe radiologist and you're hireable, all that. So, but that's the scheme, right? You have to detect the abnormality, you have to describe it and diagnose it. So each step has got its kind of merits, and that's what they are assessing. If you directly jump towards diagnosis, I think you will definitely lose marks, right? Okay. To get to the diagnosis straight away, you have to earn it. You have to demonstrate that you have got a process of approaching something, and that's how you kind of can get through most of the things. So don't jump to diagnosis. Even if you know it, try to imitate that you are kind of having a process. You've got a thinking process and all that. To detect, describe, and diagnose. And then communicate. If there is something which is really serious, or something limb-threatening, life-threatening, things like that, critical finding, obviously, you're going to pick up the phone and speak to the clinician. So that's about it. You have to replicate your day-to-day clinical practice. This is the scoring sheet. Obviously, you're aiming for something 6 or above, right? Okay. Anything below, probably, I mean, the more films you can see, probably you can have few poor answers, but the key thing is to kind of practice so that you are slick and crisp about these things, so that you see more and more cases. The more cases you see, the better chance of compensating for any shortcomings. So that's about it. Just keep that in mind. All right. So I'm going to close this, and I'm going to get the first candidate. So let me just. Sorry, let me get this out of the way. Right, so we have got the first candidate then, please.
Yes, sir.
Right, so candidate number 1, right, okay. So I'm gonna, I think what we do is I'll probably give you some control if I can, once we get to some cross-sectional imaging. But let me just put this first case up for you. So I have got a 67-year-old gentleman, and he presented with few-month history of knee pain.
For how long? 3 months.
Yeah, okay, 3 months, yeah.
So I've been presented with the X-ray knee AP view of this patient who is having complaints of knee pain for the last 3 months. and I can see that um, there's a fairly well-defined lytic lesion in the metadiaphyseal region of the femur, uh, at the medial aspect, and it looks primarily showing narrow zone of transition, and it looks primarily centered within the medulla. Uh, and Besides that, there is no obvious calcific foci which I can see within it, and uh, there is a bit of periosteal reaction, I think, in the adjoining area at the medial aspect. So, so in my routine practice, I would like to see an orthogonal view for it as well, uh, if that is available. Okay. So on the lateral projection, again, I can see that there is a fairly well-defined lytic area in the metadiaphyseal region, and which shows a fairly narrow zone of transition, and it is primarily centered within the medullus. So uh, my differentials, and there are no other lesions which I can see in rest of the bones. Uh, there's no obvious joint diffusion which I can see. So based on these appearances, uh, my differentials would include um, um, I'd like to include a possibility of um, metastasis, considering the patient's age is around 67 years of age. So I would like to keep that as a possibility. Besides that, I don't think it fits well into any cartilaginous tumor, or because there's no chondroid matrix, and um,
Are you
which
sure
is
about that?
obvious. Yeah, I don't see any obvious cartilaginous matrix within the lesion, and
Let me show you the. Do you think this is a secondary bone tumor? Yeah.
sorry, sir.
It's a secondary lesion. It's a metastasis.
Yeah, I would like to keep that as a possibility, because I don't see any obvious chondroid metrics, and then it can't be GCT also because the site is not typical for that. And besides this, I think it can be a Brown's tumor. I can think about that also, considering if the patient is has hyperparathyroidism, history of that, which I would like to know from the background details of the patient. So.
Do you see
Uh,
any other features of secondary hyperparathyroidism on this X?
No, I don't see. Uh, no, I don't see any obvious. Maybe the bones are a little osteopenic, um, but as such, I don't see any obvious um, resorption.
How would you take it further? This is a
I would
GP.
like so I would like to correlate my find, like to discuss the case with the referring orthopedician, and would like to know the clinical profile of the patient, the background details, the history, detailed history of the patient, in case if he is a known primary for some malignancy, or if there is any history of hyperparathyroidism. And I would like to proceed with MR examination of the knee for further assessment.
I'll give you the MR, but I will tell you that the patient had thyroid surgery about 1 year back. But I'm going to show you the MRI now. Let me. I have got a coronal PD suppressed. Let me see if I can give you the control. Or then I install it for you. I don't know whether I can. Let me see. You candidate one also. Let's see. Okay, let's see if you can scroll it. Can you scroll
Okay,
it?
I'll just ask for the, yeah. Um, I'll just try to scroll. I think I've been already allotted the control, I think. Yeah. I'll just try to scroll this.
All right. Okay.
I can't see the toolbar over there to
Just a
drag the
second.
image.
Just a second. Let's. What I'll do is I'll give you this so that you don't fiddle with the hindering. Just scroll now. All right.
Um,
Just use the roller mouse or the roller ball, I think, rather than fiddling with the window. Okay.
no, it's not. The images are not moving.
I think they're moving a bit, but okay, okay then. Let me scroll it for all of you. All right, let's
Okay.
just get out of it. All right, so I'm just going from posterior to anterior.
Okay. Okay, so these are the coronal images of the same patient, coronal MRI images, star images. And here again, I can see the same lesion, which is centered in the metadiaphyseal location. And it looks aggressive to me because it's not very well defined on these MR images. Uh, Besides this, I can see some areas of hypointensity, marked hypointensity in the central portion of the lesion. But there's no obvious cortical break which I can see, although it seems to be reaching up to the inner cortical margin of the bone at the probably at the medial aspect. Um, but I don't see any obvious cortical involvement or
So you,
extraosseous. Yeah.
I'll give you an axial view. Does it add to what you've already said?
Yeah, I don't think there's much to add. Yeah, it's all well centered within the medulla only, and I can't see any definite cortical involvement in this.
So what's your diagnosis? Or what's your differential diagnosis?
Since the patient had a history of thyroid surgery in the past, so I would like to know the histopath report of that patient, or for what reason the thyroid surgery was done. In case the patient had thyroid malignancy diagnosed at that point of time, this could represent a metastatic focus, and I would like to um, uh, uh, get the skeletal assessment through a bone scan or
Right. So let me just show
for.
you. Let me just show you a post contrast, and I want you to describe the lead. Uh, this is a post contrast coronal even fat suppressed images. I'll leave that for you there. I mean, how would you describe that lesion?
So there is heterogeneous enhancement of this lesion with some areas which are non-enhancing, um, and along with that, I can see uh, some enhancement along the cortical surface as well, uh, which could be periosteal reaction. Uh,
It makes you think. I mean, is it common with metastases? That's correct.
no, with metastasis, it's not that common, although. So. Uh, I would I would also like to know if the patient is having history of any fever. So are the diffusion weighted images also available in this patient?
Why you want to see the weighted image? I can show you a T1 weighted image. I don't have diffusion now. This is a T1 weighted image now.
Um,
Okay.
so I would like to add infection as well as another differential in this case, but I would definitely like to correlate with the with the overall biochemical parameters and history or clinical profile of the patient. If the patient is having fever or
It is
some sort of,
treated as well. There are no systemic upsets. We just has got pain.
so then I believe that if the patient has history of prior malignancy, I would think about this being a metastatic focus, and the adjoining this thing hyperintensity, which was enhancing along the cortical surface. This could be due to some leak of this lesion, because normally with metastasis we don't see this kind of periosteal reaction, and there's some edema as well in the surrounding areas. So
So, so what's the next step? How will you close this case? What will you do now?
um,
To get to the diagnosis. What will be the next step?
so we can proceed with the um, after assessing the overall clinical scenario. I would like to discuss the case with the orthopedician about my findings, and discuss if there is if we can go ahead with a biopsy of this lesion for further assessment.
Okay. All right. Let me close it there. Actually. All right.
In fact,
So,
I'll like to refer this patient to the bone center for biopsy if it's required.
yeah. Okay. Fair enough. Yeah. So, I mean, you described the findings very well on the X-ray. Right? Obviously, there is a well-defined lytic lesion in the distal medial aspect of the right femur, but it has got a kind of. I mean, if you see, there is. Uh, I mean, you can say a narrow zone of transition, but it hasn't got a complete sclerotic rim. And there is a periosteal reaction lesion, which makes you think this is a locally aggressive lesion. Right? And then I'll put the MRI there. Uh, on. So now, if you look at the MR, let's just quickly patch the question is there. So the lytic lesion that you are seeing now, if you put it together here, so the key thing is to keep your X-ray kind of findings in view, right? So that's the lytic focus, right? That corresponds to this area, which is more like a necrotic or a cystic fluid filled kind of structure. And then next to it, there is, like you said, it's a heterogeneous lesion, right? There is this kind of a lobulated lesion as well. And when you've seen that, you go back to the X-ray and you can see there is some kind of calcification there. Right? And then if I show you the lateral X-ray, there we go. You can see, I know, I mean, it's a bit difficult, but you can see the lesion there. That's the lytic lesion, right? But there is this kind of a stipple calcification as well, which is based, this is very typical of a cartilage lesion. I mean, very common to find these enchondromas or cartilage tumors there. Then if you look on MR, there is a cartilage tumor, and this necrotic bit is setting on it. So that has to, whenever you see this kind of calcification, I know you're looking for it, but when you say you're looking for it, you need to hunt for it, right? So I know probably it's not projecting that well, but once you have seen the MR, it's a heterogeneous lesion, right? With some necrotic area which corresponds to the lytic focus with periostitis. So this, obviously, there is a history of cancer, but with this kind of appearance, when you've got a cartilage component to a lesion which looks aggressive with aggressive features, you have to think about chondrosarcoma. Right? So that would be the first thing. So the way I would describe this lesion would be that there is a lytic lesion in the distal femoral metaphyses with associated periosteal reaction. There is a narrow zone of transition, but without a sclerotic rim. But I also see some chondral calcification inferiorly. I'm suspecting that this lesion is either arising from the cartilage lesion or abutting a preceding cartilage lesion. So that's the way I will describe it. Obviously, I mean, with the history of cancer, you always think about metastases. But when you look at this periostitis is there, which again makes you think a high-grade chondral lesion, because normally enchondromas won't have necrosis there, won't have periosteal reaction. So this is most likely a primary chondrosarcoma. Any questions?
So actually, I was just thinking about, like, I mean, cartilaginous tumors are usually bright on, T2, so which is why I'm not able to
Yes.
think
Well,
like.
There you go. So this is the area where you got the cartilage calcification. It's got that kind of lobulated kind of appearance, and there is kind of a chemical shift artifact as well. There's a cartilage lesion which is contiguous with the necrotic bit. So it is kind of one lesion.
Okay.
It's a heterogeneous lesion, but sitting on the cartilage. Well, it was biopsied, so the biopsy proven it is a biopsy. That's for sure. But it came back as high grade chondrocytoma.
Okay.
Okay, no worries. Next case then. I'm just gonna get the next case. So just let me close this. I'm just gonna get this. Okay, this is a 30-year-old who had a fall and he is not able to weight bear.
So I've been provided of this young man who had a fall and who could not bear weight on the right side. So on the pelvis AP view, X-ray pelvis AP view, I can see that there is a fracture on the right side, fracture right hip, and besides that, I can see a lucent area involving the femoral head and the neck region, and which seems to have again a fairly narrow zone of transition. So so this is likely a pathological fracture, which this patient has sustained, and based on this appearance, um, this lytic area has very clear, sharp margins with narrow zone of transition, and there is no associated obvious periosteal reaction, which I can see. There is no obvious chondroid or osseous matrix within the lesion, and there are no other such lesions anywhere else which I can see in the view provided. So based on these, I believe that this is a non-aggressive lesion, and but because of this, the patient has sustained a pathological fracture on the right side, and the possible differentials which I can think for this lesion include include a GCT, or or this could be a simple bone cyst, or
What do you
this
think?
could be.
Sorry to interrupt you, but what do you think about the femoral head?
Femoral head looks a bit deformed to me. The contour appears distorted, and um,
Why would that be?
sorry, sir.
How would you how would you explain that? You think a simple bone cyst can do that?
Um, uh, Maybe because there was a lesion already sitting there, and the patient was bearing weight. So
Right. So differentially, you said giant cell tumor, simple bone cyst,
yeah,
and
simple bone cyst, yeah, or maybe a lipoma. Mm,
lymphoma. Oh, it's okay.
based uh, um,
Okay. So how would you like to proceed? You want to see another view on this?
yeah.
Add much to it. So I've got a
So
CT, I've got an MRI. What would you go for?
I'd like to go for MRI.
Okay, which sequence?
I'd like to go for stress sequence.
Okay.
I'd like to go for T2 as well as stir.
Okay. I'll show you. Then let's start with the T2 then. All right. So that's a T2
Okay.
weighted
Okay, sir.
dedicated axial images of the right hip. In the for all of you. So let's start from here. Okay, that's distal going proximally now.
Okay, so the lesion looks hypointense predominantly, although heterogeneous, but predominantly hypointense on the T2 weighted images, and um, it looks like as if the cortical lines are not looking intact. Uh, so it looks a little aggressive to me on these T2 weighted images, uh,
Uh,
at least locally aggressive to me.
there we go. So that's a
Yeah,
coronal stent.
yeah.
Right. What does that add to what you said?
Uh, no, I don't think much I can add on this.
So you
So,
don't see
but
the
at least it doesn't look like a simple cyst or a lipoma to me based on the stir appearances or T2 appearances. So,
that's a
I'd still like to consider GCT, maybe locally aggressive GCT variety as a DD for this case and with associated pathological fracture. Um,
okay. Right. So how would you proceed?
I would. Besides, I believe that fibrous dysplasia is also a possibility, although less likely because they on the X-ray there was not typical ground glassing within the lesion, which I could see on the X-ray, and the lesion also appears heterogeneously bright on T2 star images. So
I'll
that
just,
appears to be a less likely possibility.
okay, I'll
Yes,
show
sir.
you a post contrast. All right. This is axial
Okay.
post contrast.
So,
What do you see there? There's one finding that you can see on this image.
uh, the lesion looks aggressive anteriorly. It seems that it has breached the cortex and gone out. So,
So will that you still keep DCT as your top differential, or would you like to add something else?
I can keep GCT, I think, because GCTs can be aggressive at times, also locally aggressive. Uh, and besides that, considering the patient is young, uh, and it is
Yeah. Okay. All right. So what would the next step? What will you do next?
um, I think I would like to discuss the case with the orthopedician and compare with any previous radiographs and inquire about any significant history if the patient has, if that can help in further narrowing the differentials. Um, Besides that, um, I'll also discuss about the possibility of referring the patient to a bone center for possible biopsy if required.
Okay, good. So let's just go back to the X-ray. So I think this case is, it just kind of demonstrates that you've got a big hole. It looks like a big hole in the bone, right? Okay. Not every hole in the
Yeah.
bone is a cyst. So whenever we see a lytic lesion, it means that the calcified bone has been replaced by something which is not bone. It could be fluid-filled cyst, it could be blood-filled cyst, it could be a cellular tumor, it could be a fibrous tumor, whatever. But what it's been replaced by something. And in a young guy, you can see, I mean, Perna, you can see there's a narrow zonal transition. But again, I mean, if you see hair, it's not a sclerotic rim, all right? Okay. it's kind of reasonably well defined, but it's quite an extensive lesion that goes into the femoral head and neck. And there is a cortical breach at the inferior cortex. I think that's what you were referring to, that there's a pathological fracture there. I think it's important to say where is the fracture, right?
Okay.
So a large lytic lesion involving the right femoral head and neck in a young guy with an inferior cortical break consistent with a pathological fracture. Also note irregular contour of the femoral head with sclerosis, which makes me think either there is some bone formation or either there is avascular necrosis because the lesion might be impairing the blood supply to the femoral head. Okay? I think that's something which we can infer. And then when we go to the MR, you very nicely kind of said that it's a heterogeneous lesion which is T2 hypointense. Go back to the T2. And T2 hypointense, obviously, it makes you think about hemosiderin, in DCT, it could be fibrous, it could be some bone formation there, which we are not able to say on this. We're not seeing much cloudy matrix like osteoid metric X-ray, but sometimes you can have a little bit of bone which you can't see on X-ray. The other thing is there is some cystic change there as well. So, and then exosseous extension, that's very important. That whenever you see that, it means it's a very aggressive one. I think in this, right, the top impression will be giant cell tumor, yes, or it could be Ewing cell, or it could be osteosarcoma. I think you can't rule out osteosarcoma. The my top differential was giant cell tumor. We biopsied it, and it came back as telangiectatic osteosarcoma. We were surprised about it. But again, I mean, telangiectatic, you would expect to see a lot of ABC change, but this could be just a atypical one. And particularly when there's a fracture through it, then the enhancement is usually not that much because the blood supply is obscured, it's kind of impaired. So that's it. I mean, but I think, yeah, I mean, DCT was a good call, but always put Ewing's and osteosarcoma as well in the debate. Okay. Good. All right. Next case for you. Get this one. Right. Okay, I've got a 35-year-old, and he's got a few month history of worsening knee pain. A second, I'll get to the correct view.
So,
Oh, wait. Just a second. All right. And the 35-year-old worsening knee pain. And you've got a non-weight bearing body.
so I've been provided with this X-ray right knee AP view of a patient who is having worsening pain for the past few months, and here I can see that um, I can see that the patella doesn't look like uniformly dense to me. Uh,
I would never comment about patella on an AP unless you're absolutely sure. So never start with the patella on an AP radiograph. Right? You look for other things, and obviously, then if everything looks fine, then you can come to the patella. But keep the patella on AP. I mean, obviously, I'm going to show you the lateral later on. So keep your patellar kind of assessment for that. That's for just a general tip. So
um, 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 I'm not very sure about the findings on this frontal projection. So I would like to see the orthogonal view also if they're available. Although I'm suspecting that there is something there in the lateral femoral. There could be something in the lateral femoral condyle. Okay, so these are the lateral projections of the same patient, and
okay.
um,
I windowed it for all of you because just for you to appreciate what I
so in this I can see that
What are the positive findings? Let's talk about that.
Yeah, just trying to look at. I can s- I can see some linear lucencies at the distal femoral condyle. I'm not sure about the size. So can you put both the X-rays together, the AP and the lateral views, if possible?
I will, but what's going to help you on the lateral radiograph? Do you see any abnormality which you're sure about? Let's forget the bones for the time being. What else do you see? Do you see anything that you will put in
Uh,
your report?
okay, I'm just trying to see. Um maybe there is some the joint effusion because there's some density
Okay,
which
yeah.
I can see in the subpapillar fossa.
All right. So you see a joint effusion, yes. All right. And then you follow it down. You see anything else? What about this fat pad?
So that's the first fact, but yeah.
Yeah.
Uh,
Uh, does it lead you to the abnormality?
um, maybe the uh, uh, maybe the tibal plateau is not that smooth at anterior aspects. Mm,
Oh, okay. So this patient has got knee pain. He's got a effusion. So the next step will be to do an MR, isn't it?
yeah, I'd like to proceed with MRI because
So let's see if the MRI. Then I think when we see it, then we can come with uh, make it bigger. So this is sagittal PD fat sequester.
okay, yeah, this I was seeing on the at the femoral this thing condyle on the lateral view also. So okay, so there seems to be an big osteochondral lesion at the femoral condyle. Besides that, I can see that there is some joint effusion as well, and I can see some altered signal at the tibial plateau also, and which I would like to correlate with the other imaging sequences as well, the T1 weighted and the rest of the sequences if they're available.
This is a coronal T1 weighted. Let me show you. So what do you see on that?
Uh, yeah, I would like to look at the medial tibial plateau, sir.
Well, you got abnormality there. How does it look like on T1?
Which, sorry, sir.
Well, you have seen the abnormality here on the
Yeah,
fat septum.
that's yeah. So that's an osteochondral lesion, and I don't see a rim of hyperintensity around it, around this lesion on these PDFS sequences. So I believe that this is probably not unstable, and but still I would like to correlate my findings on other sequences, PDFS axial and rest of the images to look for any loose bone fragment which might be there, and which might be picked up on other views.
I'll give you a post contrast one, all right? So somebody said, let's give contrast to the patient. All right? Okay. This is a post
So can I
contrast.
know the age of the patient?
35-year-old.
Okay. Okay, so on the post contrast images, I can see that there is thick rim of enhancement around this lesion, and there's a lot of edema seen surrounding it, and which is also showing enhancement. So, considering the degree of enhancement which I'm seeing, I also suspect that this could be due to infective etiology, and this could represent an abscess. Although it is located in the epiphyseal location, so I believe that this is a relatively uh, uh, relatively an unusual location for a bone abscess to form because usually Usually they are centered in the metaphyseal location. Um, but considering the overall appearances, I would also like to confirm my findings on the diffusion weighted images, because if this is an abscess, it will show dense restriction. Um, so
What else can it be if it's not an abscess? What's the differential you have for epiphyseal lesions?
So uh, for the epiphyseal location lesions, there's so much of edema, and considering the second possibility I was thinking about was chondroblastoma, but considering the patient is 35 years of age, I don't think it can be a chondroblastoma, because the patient is slightly in the higher age group, and chondroblastomas usually tend to affect patients who are relatively younger. Uh,
All right. Okay. And the other thing is, I mean, obviously there is small kind of effusion, which we have seen on the X-ray as well, and there are lymph nodes as well. So yeah, I mean, the thing is, I know it's a difficult X-ray, right? Okay, but the key thing is, all of you, if you look at the lateral X-ray, there is an effusion, right? And then when you come track it down, you see the Hoffer's pipeette is a bit dirty. And then you look at the femoral fauna, you can see now. I mean, in retrospect, it's easy, but I know it's difficult. You can just follow it, and sometimes it can be quite subtle, right? Like that.
yeah.
But it is there. It is a subchondral lesion, right? Okay, and on this, the edema is disproportionate, right? If it was an acute traumatic subchondral fracture or osteochondral lesion, you don't get that degree of edema. And on T1 weighted image, there was this T1 hyperintense. This is a non-contrast T1 kind of sequence. And you can see that there is this slightly hyperintense granulation tissue, which avidly enhances. So when you talk about epiphyseal lesions, obviously you think about, you said chondroblastoma, or obviously that will be kind of young, as somebody less than 20, and they'll have some chondral kind of matrix in it, or might have some ABC change in it. The other is clear cell chondrosarcoma. But Brody's abscess is always kind of, I mean, obviously it can be in the metaphysis, but it's in the differential of subchondral or epiphyseal lesion. Right? Okay. So this is an infection. This is like I said, this is a focal osteomyelitis with abscess formation. So this would need kind of further. I mean, we can aspirate the knee, and we can biopsy it. In this case, this came back as a tuberculous abscess. So yeah, that's it basically. I mean, I know it was a difficult one, but remember that when you got a subchondral lesion, I mean, obviously you could, I mean, one could have thought it's a small GCT probably on this, because again, it's subchondral, but it's not as extensile and it's not as aggressive looking. Though, I mean, if you look here, it's quite ill-defined. It's got a wide zone of transition on the X-ray. So sometimes, I mean, the X-rays can be quite tricky, but when you are given with this kind of appearance, this is an abscess with that kind of reactive edema, or an inflammatory lesion of some sort. All right, great, thank you. I think let's probably switch the candidates. I think you did well. I think you described findings well, but probably just keep your differential a bit widened. That's it, because sometimes things can be, it might not be very typical. In your case, I think you did well. Thank you.
Thank you, sir.
Let's close this, and then let's change the candidates then.
Hi.
Hello, hi. Candidate number 2, yeah?
That's right.
Let me get the, it's for you then. Okay, let's do this. All right, okay, let's get this. So I have got a 28-year-old guy, and he presented with severe leg pain.
Okay, so I'm presented with AP projection off the lumbar and upper half of the pelvis. I can see normal bone alignment. Looking at the SI joints to check if there's any sclerosis. slight reduction of the joint spaces, but I can't appreciate any sort of focal sclerosis. Looking at the sort of pedicles, I can't see any sort of missing pedicles. Can't appreciate any gross fracture. Obviously, this is an AP projection. Now, this is a patient that's come in with severe leg pain. Obviously, in my day-to-day practice, I'd also look at a lateral projection too at the same time. I can't see anything that's sort of jumping at me at the moment. I'm looking for sort of any bamboo spine or any ankylosis. Can't
How do you
read.
look for missing pedicles?
Sorry?
You said you're looking for any missing pedicle.
Yep, so I'm just kind of another scout through because you just zoomed in just now, basically. So working my way from top to bottom, I could probably appreciate, I mean, there's some bowel gas overlying, but probably the L5 on the left side doesn't look evidently clear. This could be concerning for an underlying etiology. The patient's 30. A neoplastic process comes into my mind. I'd also look out on the lateral too to check if this lesion is sort of aggressive in nature. Looking at the lateral projection, the bone alignments well articulated, the anterior posterior line. Can't really appreciate any true anterior listhesis. Looking at the L5 vertebral body, it looks slightly sclerotic, maybe slightly reduction in size as well. I'm just trying to work out if there's a fracture through there, but can't really appreciate that. So overall, we've got a case of a missing L5 pedicle with some sclerosis of the L5 vertebral body. Differentials for this could be thinking of sort of neoplastic process, patient's 30-year-old. I'll be concerned for sort of potential lymphoma given the degree of sclerosis. I'd correlate with patient's clinical history. Other sort of differentials to consider would be if there's a vertebral hemangioma wouldn't present like that, given that's also a missing pedicle.
Could this be congenital?
Or
developmental, for that matter?
So congenital, I can't see any sort of lumbar sacralization given it's sort of in the L5 region. I'd be less inclined to think a congenital anomaly would present like this. Infection again would be not within. I can't see any sort of reduction in the joint space or anything along those lines between the vertebral bodies or flattening of the vertebral bodies. So there'll be other things I'll be thinking about as Langerhans histiocytosis. Again, the age is not appropriate. Patient's 30. And other sort of bone forming tumors that could occur in that particular region, sort of benign etiology.
Okay, so what's the next step? What would you like to advise?
I'd ask for an MRI. I'd also compare with previous to know if there was any previous imaging to see if this is a long-standing issue or if this is noted in the patient's history from prior. But if not, and obviously if there's any background history of sort of hematological malignancies, but otherwise I'd do an MRI lumbar spine for further characterization.
Which sequence would you like to see?
I'd like to look at the stir sequence.
Okay, so I've got a stir. Wait. did them post contrast, but let me see. You can start with a sagittal T2 if you.
Okay.
There we go. Wait. No, I've got it there. Yeah, sorry. Silly. Right. Okay. That's a sagittal star. I'll scroll it for you guys.
So there's hyperintensity of the L5 vertebral body causing mild sort of expansion. It looks looking for any sort of septation. It's causing some mild posterior indentation of the fecal sac area, but no sort of cauda type presentation. So this is the coronal. There's some sort of I can see some linear septations within this lesion, some with a extravertebral body component attached to it. Just trying to delineate further if it's causing some.
Let me give you the axial then. Yeah. Okay. That's axial T2.
Yes, right. So looking at the area in contest that was seen, basically, this is causing some expansion of the pedicle, also involving, I believe, the sacrum. On this slice, I think it's either the vertebral body.
Now let me get to the sacrum. So that's the sacrum there, and that we're going up.
Not involved. So it's the L5 body that's expanded. The pedicle is probably causing some foraminal stenosis, exit foraminal stenosis of that region of the left side, which is probably what's causing the patient's symptom of the exit foramen of the lateral recess region at that level. This lesion is T2 sort of hypointense, well-defined, expanded. So I've been thinking about a benign bone lesion than anything else. Differentials that come to mind would be Cordoba would be one, but typically is in the sacrum. I'll be also thinking about sort of epiphyseal-based lesions. So sort of GCT will be within the differential. I'll be thinking about chondroblastoma, less likely, but I'm down because obviously I can't see any matrix type. I couldn't appreciate any chondroid matrix on the plain film. So those would be my top differentials. I would refer my findings back to the orthopedic team or referring clinician, and this needs neurosurgical opinion too, given that there is compression of the lateral recess, and this might need decompression given the patient's symptoms as well at the same time.
Okay, good. All right. Yeah. So, I mean, whenever a spine X-ray goes up, I think obviously these are like the pet things that you have to look for pedicles, and because there are so many pedicles there, so in a glance you might kind of skip it. So it's good practice to look at each vertebrae. See, I'm looking at lumbar vertebrae 1, 2, 3. The pedicles are okay, and then suddenly, yeah, I mean, you can see that there is something missing there, right? The owl eyes are there, but there's the left eye is missing, right? So that's a way to, whenever a spine X-ray goes up, you look for ivory vertebra or a missing pedicle, all right? Or look at the sacrum and things like that. These are like typical things. So yeah, you found that, and then when you go to the lateral, obviously, then you can see that there is some abnormality, there is some lucency there. And let's just go back to the AP again, because there's one more finding here. That if you see, you can see the L4 transverse process. Over here, it's a bit, I know there's bubble gas, but I mean, you can see the transverse process here. Probably it's missing here as well, but obviously that's probably not projecting that well. But there is a lytic process going on there. It is highly concerning. And then when you look at the MR, you can see there's a large lobulated lesion, which is replacing the vertebral body, going into the epidural space, going into the transverse process. All right, you see the transverse process there. It's going into it there. It is expensile. It's making it bigger, right? It's an expensile lobulated T2 hypointense lesion. So T2 hypointense lesions, I mean, it can be fibrous, it can be hemosiderin, And in this age group, I mean, whenever I see a large expansile lesion, which is T2 hypo-intense in a young guy, you have to think about GCT. This is a typical location. It can be, usually it's in the vertebral body or it goes into the posterior elements. It doesn't have any ABC change, right? But this is a GCT unless proven otherwise. Obviously, chordoma, you can put chordoma, but chordomas are usually T2 hyper-intense because they're more like gelatinous and mucinous kind of material. Chondral, again, chondral will be more like there's some calcification. I mean, this lobulation might give you a bit chondral kind of, you might start thinking about that, but there's no kind of T2 hyper-intensity again. So yeah, this was biopsy proven. It came back as GCT. All right. So GCT, I mean, so GCT, we always think about large joints, sub kind of chondral, that kind of a thing, but they can happen anywhere, and particularly in the spine as well. So that was the GCT. If it was, let's say, if it was a 60-year-old, then obviously you won't put GCT as your first differential. You would put like metastases from RCC or from lung or breast or bowel, things like that, right? Okay, good. All right, okay, let's move on. Let me just cross that. Okay, let me something. Okay. Just a second. Right, okay. So I've got a 3-year-old and he presented to ED with limb.
Okay. So I'm presented with X-ray of an immature 3-year-old patient of the femur and pelvis. So on first glance, I can't, looking for sort of any gross abnormalities to begin with. So the first thing I'm going to look for is see if there's any fracture, which I can't seem to appreciate, although the images are not projecting so well on my screen.
Is it better now? Oh, it's a bit
yeah.
dark. Okay.
So yeah, so there's no obvious sort of fractures. I'm just looking for any sort of any obvious bone lesion, which again I can't seem to appreciate. Looking at the femoral heads, so looking to see they look relatively symmetrical. So I'm looking to see if there's any. I can't appreciate any sclerosis of the femoral, of the epiphysis, shall I say, of the femora. Looking at the right side, just trying to look at the shape of the femora. Probably some slight chance of sclerosis, but I don't think there's anything to be of any concern. The acetabulum looks unremarkable. Can't appreciate any sort of periosteal reaction. I'm looking at sort of soft tissue areas too at the same time to see if if something jumps at me, and I can't appreciate.
How do you look for periosteal reaction? Right? Is there any abnormality there that makes you think there could be some periosteal reaction somewhere?
So given the sort of age of the patient, so other things, I mean, I'm not sure of the history of the patient. So the first thing I'll be thinking about is there any sort of, non-accidental injury, sort of corner sort of metaphyseal corner fractures and things like that. I'll be looking for, which I can't seem to appreciate.
Where would you
again,
what do you, I mean, where do you normally look for metaphyseal corner fractures?
At the ends of the femur.
Right. Which ends?
The distal end.
Right. What about the proximal end then?
So looking, typically it's usually at the distal end, but looking at the proximal end, yeah, I mean, so there's probably bilateral. I mean, actually, on reviewing this X-ray, I can probably see there are some periosteal reaction going on in both proximal metaphyseal and the sort of metaphyseal region symmetrical.
Okay, let's pause there for a minute. I'll show you a knee radiograph now. Right. Okay, let me get a knee radiograph for this patient. Just a second. Okay. Right. So that's a knee radiograph there for you on the left side. Do you see anything there?
Okay, so I can see some sclerotic, dense metaphyseal bands of the femur, and there's a reduction of the epiphysis of the femur. The tibia and fibula are sort of remarkable. So there's some sort of sclerotic, patchy changes going on within the epiphysis, and sclerosis of the metaphysis. So differential for this is sort of dense metaphyseal bands. So I'll be thinking of a background of sort of lymphoma.
So like I think once you start kind of going at one track, try to kind of exhaust that, right? We said that there were some metaphyseal kind of corner abnormalities, bilateral symmetrical in the proximal femora, right? Which is an unusual site. You said it's probably distal femoral. So where do you look for metaphyseal corners in the distal femur? Do you see anything here? Or are you happy that there is nothing? That was just a spurious finding, or it's an insignificant finding? Because once you start thinking about NAI, then you should kind of make an effort. You need to kind of really kind of grill or kind of or drill yourself that, yeah, that's that I've exhausted. I'm happy that what the more abnormality significant is this kind of epiphyseal irregularity or these things. So if you look at the, I mean, I know I'm kind of interjecting here, but if you look here, you see there?
Some sort of flaring going on.
Flaring, or I mean, you can see this corner is quite nicely crisp, right? This corner is not crisp, and there is a line here, right? And it is a metaphyseal corner. This is a metaphyseal corner, and then you go back to the previous X-ray that I have shown you. Sorry, this one, that one. I mean, I know this is symmetrical, which makes you think about something dysplasia, something kind of congenital, that kind of thing. But these are metaphyseal corners as well. Right?
Okay, so metaphyseal corner fracture at the proximal end.
Fractures. But I mean, this is very typical for metaphyseal corner fracture. Distal femur at the medial aspect of it. That's a metaphyseal corner fracture in somebody who's limping. You always have to kind of raise concern for that. And with this and this, you got three areas where there is metaphyseal corner abnormality. It doesn't look like rickets. It doesn't look like typical of scurvy. But there's no definite other lesion or makes you think there's got osteosarcoma or anything like that. So this is like three areas. 3 metaphyseal corners, which is abnormal in a 3-year-old. What else do you need? Right? So it's just like, I mean, you were thinking correctly. I mean, I was pleasantly surprised that you're thinking at the right thing. This is something you don't miss. I know this talk is about bone lesions, but bone lesions are not only tumors, not only infection. They can be metabolic. They can be these things as well. This is a bony lesion, bony abnormality, isn't it? So yeah. So these are metaphyseal corner fractures. Okay. I know this is a tricky one. That's why I showed you. So sometimes in exam they show you a tricky thing that's symmetrical, but they want you to get that. And you said it. I'm looking for metaphyseal corner fractures. So I mean, probably you guys need to kind of read about it, how they look like, and then kind of different. They could have different morphologies depending on which stage they are. But this is a cortical break at the metaphyseal corners. This is a cortical break at a metaphyseal corner. So that's what they are. Anyways, that's fine. Good. All right. Let me show you the last case for you. All right. Okay. I'll just. So yeah. Sometimes it's usually in the history, isn't it? That's all kind of what you, because this is something you don't want to miss in real life, let alone in the exam. Okay. Let me get you this one. Okay. Sorry. All right. Okay. This is a 10-year-old. No, not 10. Wait. Let me see how old is this guy. I think probably 5 or. Sorry. That is. Wait. No, sorry, beg your pardon. He's 10-year-old, and he presented with limb.
Okay, so I'm presented with an immature pelvic X-ray. So I'm looking on first glance. You can see that there is a slight reduction of the right femoral epiphysis comparison to the left. But I can't see any other sort of focal abnormalities sort of jumping at me at this moment.
I want you to take 1 minute and kind of try to trace the pelvis and whichever bones you can see. I want you to spend, all of you, to look at it for a minute.
Okay,
Or you can talk what you're looking at. Fair enough. If you want to think and talk together, that's fine. But take a half a minute. Just sit back a bit and just look at the left and the right side and look for any asymmetry or anything that stands out.
So
Right. Sorry. Okay. There we go. All right.
fine. So I'm looking at the ilium bone. So both ilium bones look unremarkable. Coming down to the pubic bone. Pubic bone looks unremarkable.
What do you mean by pubic bone? How do you look for pubic bones?
I was just looking at the pubic symphysis region to check, but I could see there's slight sclerosis, but I think that's probably some overlying sort of bowel gas pattern and some fecal matter in the rectosigmoid region. Normally in this age category, you know, I'd be thinking about DDH and things like that, basically, but the femoral epiphysis, even though initially I thought the right side looked smaller than the left, they look relatively symmetrical.
It's a bit tilted or a bit slightly rotated on the left, I think. But
yeah,
the hips are okay.
Hips, yeah. So the other thing I was sort of focused on actually in retrospect, I'd like to say is, I mean, on the left ilium, there looks to be an area of lucency. Doesn't demonstrate any cortical breach.
Yes. Ignore that. That's fine. There's nothing in the ilium.
So the SI joints look okay as well, to be honest. Maybe the sacroiliac look a bit of lucency within the sacroiliac. Sacroiliac joints maybe slightly widened, but
Young guy.
Young, yeah.
So I think, so that's good that we are doing this exercise, because I think it's very important to know that on a pelvic radiograph, there are these review areas. You look at the sacroiliac joint, you look at the sacrum, you look at the iliac blades, edge of the film, proximal femora, look at the acetabulum, right? Okay, acetabulum looks symmetrical. Okay. Obturator foramina, they look fine, right? Okay. I'm going to magnify it now for all of you, because I don't want to give you a spoiler, but I'm going to magnify it now so that you can there's no harm in magnifying if you can't kind of see a definite normality. Say in my normal practice, I would like to magnify the hips.
So are we looking at the left tubical region that looks a bit sclerotic? Are we?
Yeah, this is the area that you were saying is probably because of the fecal load or something, right? But does it stop there? Does it stop there? That is the question. It doesn't stop there, isn't it? It goes.
It continues all the way up to superior pubic rami.
Yeah. So so there is asymmetry, right? Okay. So you see that this is nice, kind of normal, kind of superior pubic ramus. What about this one? It's subtle, but it is, once you have spotted it, you can't kind of ignore it. You see? There we go. Yeah. Okay. So anything else before I show you the MR then?
I think that the MR would be a bit more. I mean, compared to previous, if there is a previous.
No, I don't have a previous one. No. So in a 10-year-old, if you got a sclerotic diffuse, like, but this has got a wide zone of transition, isn't it? This is like the whole bone is kind of involved with sclerosis. Yeah. What would you be thinking?
So wide zone of transition, sclerotic. I'll be thinking about an aggressive process, and
give me three aggressive processes that you would think in somebody who's 10-year-old.
10-year-olds, I'll be thinking about Ewing sarcoma, osteosarcoma, osteomyelitis.
Yeah, okay. Right. Okay. Let me show you the MR now. I think we'll probably start with a coronal stab. And if I get rid of this so that we can juxtapose them, we'll put this up there.
So looking at this coronal sequence, I can see that there is high hyperintensity of the superior pubic rami with involvement of the pubic tubercle also involved, causing some expansion with some soft tissue component associated with it, which in retrospect can possibly be appreciated on the pelvic radiograph, which looks relatively loosened.
It's difficult to kind of be sure about that, but yeah, now in retrospect it's easy. But yeah, okay, so right, what else on the MR you would like to add before you give me a differential then, or improve upon the differential you've already given me?
So I'll check for post-contrast images as well at the same time to check if this lesion is also enhancing along with its soft tissue component.
I don't think so we gave contrast in this kid. I can give you an axial. That's a gradient kind of thing. Okay. Yeah, that's moving. I'll give you just this T1. Then we can. Oh, sorry. Not coming. There.
Okay, so
I mean, that sclerosis that you were seeing, I mean, it's quite T1 hypo intense.
Intense on the T1, yeah, and there's no. I mean, I can see some cortical breach with some soft tissue component. So, and low on T1. So this is likely in keeping with, given the patient's ages of 10. And
is somebody else using it? Because I mean, I don't know. Probably, are you able to scroll these images? They're flipping. Anyways, that's okay. So yeah, you win. All right. Okay. Yeah. What else? I mean, I know. I mean, the other thing. Can you think about any tumor that can secondarily involve the bone in that area?
That can secondary involve the bone. I mean, osteosarc, LCH, but again, that wouldn't give you a soft tissue component.
Okay.
Other than that, I've been thinking about sort of.
Which structure is it? What's that structure there?
That's the bladder.
Right. Okay. I mean, in this case, you can see that probably there is a plane between this kind of tumor.
Not involving the bladder wall.
Right. But just for sake of argument, if you could see it kind of contiguous with the bladder wall.
Yeah. Then I'll be thinking about rhabdomyosarcoma.
Exactly. Yeah. Good. All right. Yeah. So yeah, good. I know. I mean, this was a difficult, and my apologies for that. But I just wanted all of you to look at this because pelvis is a haystack unless you got a scheme and you got a good habit, like an X-ray, like a chest X-ray. You need to look. You need to compare like with like, and then I know. I mean, probably it's a difficult film. I think you guys most probably say it's a difficult film. But once you've seen this diffuse sclerosis in somebody who is young, I think you can't ignore that. I mean, you can think about CRMO, osteomyelitis, LCH, but this would need further imaging. And then lo and behold, it was biopsied and it came as Ewing sarcoma. Yeah. All right. Okay. Well done. So the way I would describe is that there's diffuse sclerosis of the left superior pubic ramus extending into the pubic body with probably some kind of soft tissue involvement. Or if you magnify, then you can see there is subtle kind of periosteal reaction, very subtle, faint kind of thing. It's good on my screen, but probably not on your screen. And then this is concerning for a bone-forming tumor or an infiltrative process. That's how I would say. And then obviously this would need further assessment with MR and take on from there. Good. Yep. All right.
Thank you.
Okay. Well done. Right. Great. Okay. Candidate number 3. I know we're running a bit kind of behind schedule.
Sorry, Asad, just if you can give me a moment, just an announcement on my end. This is for the audience.
Yes,
This
please.
is regarding the next Thursday. Next Thursday, you remember I was covering A to Z course MSK last time and I could not complete it. So I'm going to complete it and I will cover metabolic, endocrine, and soft tissues. So that will be MSK A to Z, whatever is left. So that will be next Thursday. Thank you very much, Asad. Please continue.
Thank you, sir. Right. Okay. So candidate number 3, I'm going to get the.
Do you hear me, sir?
Hi, you can hear me? Yeah.
Yes.
All right. Okay. So let me show you the first case then, please. Okay. There we go. All right. Okay. So we're moving from a 10-year-old to a 35-year-old who has got a painful limb. And that's a pelvic radiograph for you.
Well, I am presented with X-ray pelvis frontal projection of a young adult in which I can appreciate the abnormality in the left hip joint.
Excuse me, madam. Can you please? We can barely hear you. Can you please speak up, or something is wrong with your? Can you just speak for a sentence? Volume is the issue here.
Madam, sir, do you hear me?
I can barely hear you.
Yes. Sir, just let me disconnect and connect again if you can easily.
So if you can just speak up, if you can just speak up, there is a problem. Just try to speak with a increased volume, should I say. Thank you.
Well, I am presented with X-ray pelvis frontal projection. Sir, is it clear now?
Yeah, it's better. Yeah, please carry on. Thanks.
I can appreciate there is abnormality in the left hip joint with reduced joint space. There is sclerosis of femoral head. There is cortical irregularity.
Cortical irregularity where? Just be specific in your description.
Cortical irregularity of the femoral head. However, there is no any significant degenerative changes. In comparison, the right hip joint is normal. And looking at rest of the bones, including the bilateral iliac, pubic bones, and the ischium appears normal. My top differential would be septic arthritis going in the left hip joint.
Okay. The patient hasn't got any temperature and he's not systemically unwell.
Well, if he's having a long-standing history, then the differential would be the tuberculous arthritis or rheumatoid arthritis. However, there is no any osteophyte formation and there is no any other degenerative change, so I am going with the infectious, with the septic and tuberculous.
What do you think about this? You said cortical irregularity of the femoral head, but I would say there is cortical irregularity with this solid kind of extra bone formation laterally. Is that of any concern? There's no history of previous trauma.
Yes, now I can appreciate. There are subtle subchondral lucencies on the acetabular side and the femoral side as well, and there is, if I can say, it is a periosteal reaction on the left iliac bone.
Right. So will that change your differential now?
Yes, this will change my differential. This is some aggressive pathology going on.
Right. Okay. Like, give me a differential.
Well,
Flat bones of the pelvis in a 30-year-old.
the pathologies that involves both sides of joint includes the, well, this can be PVNS, but that is not this much aggressive.
Okay. Okay. Last thing before I show you the MRI. I mean, I want you to look at the soft tissues. Do you see any soft tissue abnormality around this, around the left acetabulum? Considering the previous cases we have seen today.
On this X-ray, I cannot appreciate because these is the periosteal reaction. I mean, it is bone related.
Right. Okay. All right. So let me show you the MRI then. Wait. Okay, let me start with this. Let me scroll and then I'll stop at one place and then you can describe the findings. All right. That's the front, going back.
Yes, these are the.
I stop there. What do you want to describe what you see?
Sir, this is coronal MRI of the pelvis in which there are abnormal bone signal intensities involving the ilium, acetabulum. So please scroll.
Okay.
With the
Ilium.
higher intensities in the surrounding soft tissues as well.
So how would you describe this soft tissue?
Yes, this is associated soft tissue.
Extraosseous soft tissue extension.
Extraosseous soft tissue that is associated with the pathology.
Okay. Let me show you the axial so that we get a better idea what we are dealing with.
Yes. Yes, I can appreciate there is locally aggressive pathology that is going in the soft tissues and in the bone as well, appearing as hyperintense on the star sequence.
Right. Okay. So you want to see something else or you want to give a differential now? I can give you a post contrast. All right. Let me.
Yes, sir.
It's not coming up. Okay, let's look at this one. This is post contrast then.
Well, I can appreciate the enhancement in the soft tissue that is associated with the pathology, with the cortical break in the bone.
Okay. Right. So in a 35-year-old, you have got an infiltrative lesion in the left acetabulum with a large extraosseous mass, probably getting into the joint. And then you have got these soft tissue masses along the iliac vessels. All right. Okay. So,
Yes, my differentials include Ewing sarcoma and
right.
osteosarcoma.
Okay. Well, Ewing and osteo, you can probably speak in the same breath. I mean, that's fine. Okay. What else? Is there
It
any
can
other
be some secondary deposit.
secondary deposit? Right. Okay. In a 30-year-old, secondary deposit from where?
Secondary deposit from some pelvic pathology.
Right. Okay. The patient had a PET scan. Okay. So I'm going to scroll it. And what do you see on this image?
I can see the increased uptake in the left humeral head and the spleen and in the corresponding place of iliac and acetabular region.
And
Humeral head, spleen, and the bilateral renal uptake.
well, that's just normal renal excretion, right? What about
Yeah.
the lesion in the
Yes,
humerus?
the left humeral head.
Okay. So
Again, it can be the metastatic deposit in the humerus.
yes. Okay. So what about the spleen then? Does that clinch the diagnosis for you? You need to just tell me what you'll do next, and then I can show you the next case then.
This can be lymphoma.
Right. Why do you say that?
It's that it is involving the spleen with the.
Yeah. Okay, good. Yeah. So the bottom line is, I mean, obviously, I mean, you can have Ewings, like we said in the previous case when there was pubic ramus kind of thing and there was extraosseous there. But if no, you look at this periosteal reaction, and what I wanted you to now in retrospect, you see there is this kind of a density here. This is the soft tissue that we were seeing.
Soft tissue, yes.
Over here, you see fat. Over here, there is obliteration of fat. I know it's difficult, but now that's the whole point of doing this exercise, that you have to make a habit of looking at any asymmetry in the soft tissues. Okay, you got abnormal bone, probably a bit of joint space narrowing, like you said, periosteal reaction. But this is what we call a permeative destruction, right? Okay, there's like diffuse something infiltrative here, not big holes like moth-eaten, but there is something, some osteopenia or something infiltrative here in contrast to the normal right acetabulum. Okay, so this will you have to think about an aggressive process in the acetabulum. Okay, with probably secondary involvement of the hip joint, and then the differential will be Ewing's or lymphoma. This was lymphoma. So lymphoma and Ewing's can look similar. I mean, lymphoma can look sclerotic and can look lytic, but whenever you see a large extraosseous soft tissue mass, like this one, look at this, it's going all the way in the greater sciatic foramen at the back. You have to think about Ewing's in somebody who's younger, like 20 or less, but anybody from 20 to 40, you have to think about lymphoma. And if it gets 40 or above, you can think about RCC or something like that, which are usually expansile metastases. So this was lymphoma. Right? Okay, good. All right, let me show you the next case then. Okay, let's get one. Okay, this is a 40-year-old, and he presented with a painful lump in his right lower leg. And I'm giving you a lateral radiograph.
Well, I am provided with X-ray of the right tibia and fibula lateral projection. There is abnormal soft tissue density mass in the anterior aspect of tibial diaphysis. It is causing mild sclerosis or mild erosion on the underlying bone. I can appreciate the cortical thickening on the anterior aspect of the tibia. There is a small calcific foci on the superior aspect of the swelling. And I would like to see the frontal projection as well for the extent.
Okay, that's the frontal projection for you.
Well, on the frontal projection, there is a periosteal reaction on the lateral aspect of the tibial diaphysis. The associated soft tissue swelling is extending medially.
Okay, good. All right. So what do you think? What are we thinking about? What's your differential diagnosis there?
So on the lateral projection, I was thinking about a benign soft tissue mass that could be the hemangioma, thinking that there is a phlebolith in the superior aspect. But I think there is a locally invasive lesion which is causing the underlying cortical erosion. And as I've seen on the frontal projection, there is slight periosteal reaction on the lateral aspect of the tibial diaphysis. So this can be the aggressive lesion with the soft tissue component as well.
Right. Okay. So you would like to get an MRI or a CT?
I would like to see MRI of this patient.
Everybody goes for MR. All right. Okay. Right. I'll give you a T1 weighted axial first. That one. Okay, let's just say. We'll do Dixon. I mean, the thing is, that's it. Right. Okay. So that's a T1 axial. I'll scroll once again for you guys. So that's the tibial tuberosity. All right. So going distally now.
Yes.
There. All right. Okay.
So there is an abnormal signal intensity soft tissue mass that is causing the erosion and involvement of the tibial cortex and extending into the muscular plane.
Right. Okay. I'll put the post contrast in.
And then I need that.
And then we can talk about what we think this could be. All right. I've got a a sagittal there. There we go. All right. Okay. So this is a post contrast. And I leave that image for all of you.
Yeah, on post contrast, the soft tissue is significantly enhancing, and again, I can notice the small speck of, flow void on the superior aspect of the soft tissue swelling. This can be the phlebolith.
Right. Okay. Well, okay. That's you're probably quite fond of phleboliths, and but I mean, when was the last time you've seen a hemangioma do this?
So there's sunburst type periosteal reaction I can see, but I'm not sure about this. So can you show me the coronal?
I'm going to show you the CT then. All right. Okay.
Okay.
We're talking about periosteal reaction, so let's get to the CT.
So please scroll it. I can.
I'll leave that there. And
Yes, there
that's
are multiple calcific foci in the soft tissues, and there is sunburst like periosteal reaction.
right. Okay. So is it an aggressive process or
Yes,
it's
this
a
is aggressive process.
right? Okay. So which aggressive process do you know that can affect the mid shaft of the tibia in a 40-year-old?
This can be osteosarcoma.
Right. Okay. Any particular form of osteosarcoma you can think about?
Parosteal osteosarcoma.
Parosteal is usually more like a thick bone forming. Is this soft tissue hasn't got much bone in it, isn't it? Okay, one is osteosarcoma, right? Okay, which other tumor that it's got a predilection to affect the tibia. Whenever you got an aggressive tibial lesion, you always have to think about it affects the mandible.
Bovine.
Sorry. Right. Okay. I think let me interject here. Right. I mean, the key thing here is that if you look at the X-ray, I mean, there is a disproportionate. I mean, we're talking about extraosseous soft tissue masses, right? With
Yes.
kind of extending out of the bone or onto the bone. In this case, if you see, there is a large extraosseous soft tissue which is causing, like you said, a large erosion of the anterior cortex, and that's quite thickened cortex actually, right? So this is whenever you get this surface scalloping. That's the other term you can use: surface scalloping or saucerization. This is usually it happens in lesions which arise from the surface of the bone, right? Either from the skin, the soft tissues, or the periosteum, right? Okay. So this one, I mean, the question now, the $1 million question here is that it is something that was there at the top and then secondarily got onto the bone, or it was in the bone and got out. So, I mean, that's always, I mean, sometimes it's easy, sometimes it's not that easy. And in this case, if I put this is the post-contrast one, I think. So you see, so there is, you can see some abnormal enhancement, abnormal signal here in contrast to this. This is fatty marrow, but this one is a bit enhancing, right? So, but, and then like you said, it has got, this is kind of, but it's got a very broad-based, this soft tissue. It's got a very broad-based on the tibia, and it breaches through the muscle planes. So
Yes.
part of me thinks it is something which is arising on the surface and then secondarily got into the bone. Okay.
Yes.
A diphyseal lesion, I mean, this could be periosteal osteosarcoma. Periosteal, not parosteal. Parosteal is the back of the knee with a very thick bone forming, solid bone forming tumor. This can be periosteal osteosarcoma. That's the one differential. The other could be adamantinoma. I mean, whenever you see aggressive lesion in the tibia, you have to think about adamantinoma. That's always, you won't be wrong if you put that in the differential. Okay. And the third thing could be, I mean, that this is some skin tumor which is secondarily gone into the bone. All right. Like, I mean, this could be that this patient, well, we biopsied this, it came as squamous cell carcinoma. I know, I mean, you'll be, or most of you will say, I mean, why I'm showing you this, but that can happen. If somebody has got a long-standing ulcer, it can get marginal ulcer, it can become secondarily infected, like chronic infection, then it can cause squamous cell kind of carcinoma, and that can invade. So we were all surprised when it came back because we were thinking it could be adamantinoma or surface periosteal osteosarcoma. But yeah, that's by the by, but that's it. Yeah. Okay. Good. So yes, you just need to, I mean, hemangioma, I mean, obviously that will have more phleboliths. Phleboliths are more round kind of structures, and hemangiomas usually, I mean, they can cause some scalloping, but they won't be this aggressive, right? Okay. Okay, last case for you. I'm gonna just get one case. Just give me a second, and then we'll get the The next candidate. I know I'm running a bit over time here, but I hope you guys are all okay with it. All right. So I have got this 3-year-old. She presented with a painful swollen forearm. Yeah, can you hear me?
Yeah, I am presented with X-ray of left forearm of a skeletally immature patient. There is abnormal, predominantly lytic and sclerotic lesion in the proximal diaphyseal region of radius with wide zone of transition. There is periosteal reaction, cortical thinning, and erosion. I can appreciate associated soft tissue swelling as well. Rest of the bones appears normal to me. I would like to see other projections for any for further evaluation. I cannot appreciate the because it is having the wide zone of transition. I cannot appreciate the upper margin of the pathology. The periosteal reaction is lamellated and parallel to the axis of the bone.
So which part of bone is involving? Where is the lesion? You said
It is it is in the proximal metaphysis and towards the diaphysis of the radius.
right. Okay. Anything else before you start giving me the differential diagnosis?
No, this is, I mean, let me summarize the things. It is a aggressive lesion of lytic and sclerotic morphology with cortical erosions and break with periosteal reaction and associated soft tissue swelling in a skeletally immature patient.
Okay. Differential diagnosis.
So the differentials include Ewing sarcoma, eosinophilic granuloma, but it has the wide zone of transition, so it is less likely.
And the third one?
It can be emerged from neuroblastoma, but again, it is having the wide zone of transition.
Right. Okay. So what will be the next step then? Or what there's another differential important one that you haven't mentioned. You said Ewing's, Langerhans cell histiocytosis, neuroblastoma metastases. There's a third one I would put in there. Which other aggressive process can look like this?
So any infective process can,
Yeah, what do you mean by infective process?
infective, it can be osteomyelitis, but that is again less likely.
Okay, all right. Right, okay, so patient had an MRI. Okay, so let me show you the axial. I'm gonna make it bigger. Starting from the wrist, going proximally. That's the elbow joint, distal biceps tendon. And I'm just gonna stop there. And I want you to describe what you see on that image for me, please.
Yes, the abnormal signal intensities are involving the soft tissues and the cortical break, and there is abnormal signals in the bone marrow as well.
Yeah, okay. I'm going to show you this then, just one long axis kind of view there. Then you're going to improve upon your differential. You've given 4. I want you to narrow down to 2, if you can. What do you see there? Just describe your findings there, please. Now you can see the full extent of the abnormality. Yeah?
Well, abnormal signals are expanding from the elbow joint of from the epiphyseal region of the radius and expanding towards the mid-diaphysis with surrounding soft tissue involvement. There is internal heterogeneous bone marrow signals, so it favors the diagnosis of osteomyelitis.
Okay. How confident are you? Are you 100% sure this is osteomyelitis? Yes or no?
Yes.
All right. So what will you tell the clinician then?
Sorry, I can't hear you.
What will you tell the clinician? You'll report this is osteomyelitis, treat it as infection, or does it need a biopsy? That's the question.
Yes, I will go for biopsy.
For what? What will you send it for?
For cytology or the culture. I mean,
For culture, that's just microbiology culture, or you would send it to pathology as well?
sir, I would like to send to pathology as well.
Right. Okay, good. Right. So differential is osteomyelitis, and what's the second one you would put?
Ewing's.
Ewing's. All right. Okay. Right. Okay. The patient had a biopsy at a sarcoma center. It was in Stanmore, actually. This patient had it. And then 1 year down the line, that's the X-ray. So what do you think this could have been? Could it be Ewing's?
No.
Right. Okay. Because yeah, I mean, Ewing won't. I mean, they'll with 1 year. I mean, this looks like a normal kind of bone now, isn't it? So what was it then?
Infection.
No.
Osteomyelitis.
Yeah, this was Langerhans histiocytosis, right? I know. I mean, you said it's not well defined and all that stuff, but you all have to think. Anybody who is 5 or less, whenever you see, well, I mean, some people will say 10-year-old. If you see an aggressive diaphyseal lesion in a 10-year-old, put LCH there because LCH is an active kind of inflammatory process. Okay, it's like leukemia, that kind of a thing. It's infiltrative, and depending on which stage you catch it in, if you catch it at an indolent stage, it can be a well-defined kind of endosteal scalloping round lesion, like a typical eosinophil granuloma. It could be an infiltrative thing like this one. And the key thing here is, you see, the lesion is here, but look at the periosteal reaction. It extends far beyond the margin of the lesion, right? Okay. So, I mean, when I looked at it, I thought this is either this is like osteomyelitis, Ewing's. That were my 2 differential. I put LCH probably in my 4th or 5th one, but when the biopsy came back, it was LCH. So the point is, diaphyseal lesion, I mean, with this kind of aggressive, this like multi-lamellated kind of reaction, which means that it's growing, then limiting, then growing and limiting kind of thing. But Ewing can have it as well. But the bottom line is, I mean, I know you said probably infection because there was a cortical break and it looked like there was a cloaca and all that, this thing there. But that can happen in LCH as well. Okay. If it was Ewing, you would expect a lot of extraosseous soft tissue mass around it. Okay. But this needs a biopsy. I mean, even if I'm 100% sure this is osteomyelitis, I would never be sure this is 100% this osteomyelitis. It needs, for culture, you're going to do biopsy anyways. Okay. So always they say that you have to culture a tumor and biopsy infection, right? Okay. So because they can look similar on MR and imaging. So you don't want to miss a cancer and treat it as an infection, and then later on patient present with metastatic disease. So it's important to kind of biopsy whenever you're suspecting an aggressive process. Okay. So yeah, that was LCH. So don't forget LCH. LCH, people always think about like a lesion in the skull vault or a Bever ledge and all that. But a diaphyseal lesion, a large expansile, aggressive-looking diaphyseal, metadiaphyseal lesion in a young child, always think about Langerhans histiocytosis. All right.
Thank you so much.
Thank you. All right. Okay, let's get to the last candidate now, please. Okay, let me close that. And I'm going to get some different case now. Right. You there? Hello?
Hello, sir.
Hey. Right. Okay. Let me get something easy then, or different one. I think we're talking about the same things over and over again, because I just wanted you guys to kind of have an idea how things can look like. Just a second, let me get that. All right, okay. Let's just start with a simple one. All right, okay, because this is a 16-year-old, and she presented with limp or knee pain. Let's put it knee pain.
Yes. I have been provided with a frontal radiograph of left knee of skeletally immature patient. I can see a partially defined sclerotic lesion involving the metadiaphysis of proximal tibia. The lesion has fairly wide zone of transition. There is no with osteoid matrix, sclerotic matrix. There is no soft tissue component. There is no associated cortical thinning or cortical destruction. So my top differential would be osteosarcoma. So no, but this is skeletally immature patient. So
What about there? Do you see anything there that will that adds to what you're saying?
I can also see periosteal reaction along the lateral aspect of tibia, along the lateral shaft.
Right, okay. You want to see the lateral radiograph?
Yes.
Okay, what kind of periosteal reaction is that? Can you elaborate on that?
It looks like interrupted, like it looks like Codman's triangle. I mean,
Right.
it's interrupted on the proximal aspect, and yeah, distally it looks like triangle. Or it could be layered also, like lamellated periosteal.
Right. Does this add to what you're saying?
Oh, so Ewing's outcome.
Right. Okay. No, I'm saying, okay, Ewing sarcoma, right? Okay. Okay. So what will be the next step then?
Sir, I would like to review the previous radiographs, and if not available, then I'll like to go for MRI.
Okay. You will go for an MRI. Okay. Let me get you another case, because that might be just a second. Okay, let me get this. Okay, let's just keep that in mind, and I'm going to show you a similar case here. This is a 18-year-old, and I want you to just on the same thing, think this is the same kind of similar kind of patient, but I want you to describe what you see here now. On this view, let's say. If you'll be quick, I'll show you more. Yeah, okay.
Yes. So I have been provided with the frontal radiograph of knee. I can see ill-defined sclerotic lesion involving the epiphysis and metaphysis of the femoral condyle. Epiphysis and metaphysis of the femur on the lateral aspect. And also there is I can see there is associated soft tissue component on the lateral aspect.
Okay, what about, I'll show you this then.
Yeah,
What?
and there are focal areas of sclerosis too on the posterior aspect of femur. So it could be paroscopy.
And
Yes.
what is this then?
Yeah, soft tissue component is also there.
Right. So what is the diagnosis?
So perosteal osteosarcoma.
This is a 16-year-old.
So I will go for Ewing sarcoma.
Okay, right. I mean, okay, I'll show you a paraosteal osteosarcoma because you guys are just kind of probably need to see that, right? In a 16-year-old, in anybody who is skeletally immature, like the around the knee, if you see a bone form, this is sclerotic, dense, cloudy kind of matrix. This is osteoid matrix, right? There's an ill-defined sclerotic bone-forming kind of lesion in the distal femoral metaepiphysis with some lucency and periosteal reaction and an extraosseous soft tissue mass. I want all of you to appreciate that. Whenever you look at an X-ray, make an habit. When you think about a bone tumor or a lesion, just see there is some, this very obvious there, right? There is something that shouldn't be there. This is extraosseous soft tissue mass with areas of bone formation within it. So the tumor started in the bone and got out of the bone. It's a bone-forming tumor, probably going into the joint as well, probably. This is osteosarcoma. Paraosteal is usually 35 to 40. There are more adults, and it'll be more like a dense block of bone at the back. I'll show you in a second. So don't go for paraosteal in somebody 15 to 20. Common things round the knee. Round the knee, you see it in the tibia, in the fibula, or in the femur. Bone-forming tumor, osteosarcoma, conventional central osteosarcoma. That's what it is, right? Okay. And obviously, then you're going to do. But I mean, I can show you this. You can. Again, you can see that what's happening here, the tumor is inside, it's going outside as well. This is a post-contrast. Probably this was, I think this was before that X-ray, because I think it looks a bit smaller. It probably kind of increased a bit in size later on. Because it doesn't look as impressive as, but there you go, you see that? So this is the image. I mean, whenever you see a lesion in the bone and you see it getting out through the break, right? This could have been Ewing's as well, but we know this is forming bone. So bone-forming tumor in the metaphysis distal femur. This is osteosarcoma, okay? And it goes into the joint. As you can see, there is extension of the joint. Right. Okay. That was. I just wanted you to have a look at that. That's fine. And this one obviously will be referred to a sarcoma center, and then we need a staging CT chest, and could be whole body MR or bone scan, depending on where you work. Okay, let me show you another case now. Okay, I think this one I'm going to put on. Let me. Okay, if I do this, right, come. Okay, this is a 2-year-old, and he presented to emergency with shortness of breath.
Yes. So I have been provided with frontal radiograph of chest of skeletally immature patient. At first glance, what I can see is a diffuse opacification of left hemithorax, which is causing mediastinal shift towards the right side. And associated with it, I can see expansion of sixth rib anteriorly and anterior part of sixth rib. So looking at the age and so it could be Ewing sarcoma with soft tissue component.
Just describe, can you just kind of take us about a minute back and just describe the finding that you're saying? Can you start again for us, please? Thank you.
Yes. So I can see expansion and mild cortical irregularity of anterior part of sixth rib with diffuse opacification of left hemithorax. And the opacification is causing, I mean, there is associated tracheomediastinal shift towards the opposite side.
Right. Okay. So what does that imply? So what's the cause of that whiteout of the left hemithorax?
That would be soft tissue component, huge soft tissue component associated with evening sarcoma.
Or it could be a large pleural effusion.
Yes,
Right.
would be that much.
So if you are working at night and you see this X-ray, what's the next step you can do to differentiate? It's a solid lesion or fluid.
I will do ultrasound for this. I mean, I will go for MRI. I will go for MRI.
MRI at night. You're going to wake up the MRI tech and come and do it, is it?
So I will go for ultrasound myself. I can.
Right. Okay. So yeah, I mean, the thing is, this X-ray, I think, I mean, you very kind of succinctly describe the finding. All of you should look at. I mean, we could probably. I mean, if I'm reporting it, I would start from the whiteout first, right? Okay. Because there is obviously complete whiteout of the left hemithorax. You can't see the diaphragms. There is significant mass effect. The trachea and heart is shifted to the other side. So there is significant mass effect there. Okay. Because if it's a collapse and effusion, then usually, I mean, the trachea won't be shifted that much because the pull and push will be kind of balancing itself out, right? Or it could be a large effusion which just kind of pulled up very acutely. But then, like you said, there is this, I think the fifth ray, probably 1, 2, 3, 4, 5. Fifth kind of anterior rib, there is an expansion. So always look at, I mean, it's quite obvious now. I mean, once you pointed out, things become very obvious. There is kind of irregularity, expansion of that. So now the question is this something that started in the lung and went into the rib or in the rib and got out? And he's a 2-year-old, right? Okay. So he had an ultrasound. And there you go. I'm going to this, yeah. I mean, this is not fluid, right? This could be a hemothorax or something, but this is, look, this is a very lobulated kind of, look at there. It's a very lobulated kind of solid mass in the chest cavity. And the next one, I'm going to show you the X-ray, and then you can, sorry, the CT, we did a CT on this. You can argue we should have done MR, but yeah, the CT is more handy when you come to chest wall and all that stuff. So you want to describe the findings there?
Oh, yes, sir. So I can see irregular soft tissue density lytic lesion involving the anterior part of fifth rib. The lesion is causing cortical destruction and there is associated large soft tissue component. The soft tissue component is showing heterogeneous enhancement with the large central necrotic cystic area.
Yeah.
Suggestive of Ewing sarcoma with soft tissue component. I mean, Ewing sarcoma.
There's a typical Ewing sarcoma, or I mean, some people use the term Ewing sarcoma. Some people will say like a round blue cell tumor, because that's kind of the broad kind of subset of it. And some people call Askin tumor. I mean, you can read about these things, but yeah, this was this biopsy, it came back as Ewing. So we have seen few Ewings today. You see, so Ewings can be in the long bones, can be in the flat bones of the pelvis, or it can be from the ribs. Okay, but the key thing is whenever you get something arising from the bone with a large disproportionate soft tissue mass in somebody who is young, less than 20, always think about Ewing sarcoma. If they're 20 to 40, you can think about lymphoma, and then thereafter it will be metastases. Right. Okay. I'm going to show the last case before I take you to the perosteal osteoarth. But I think let me get that thing, because I got that case just copied just yesterday. And okay, let me cross this. Let me get out of that. Right. So I've got a 45-year-old lady, and she presented with a painful lump in her thigh. She went to the rheumatologist, and the rheumatologist got this X-ray. I want you to explain what you see.
So I have been provided with frontal radiograph of left femur. I can see a fairly defined sclerotic lesion in soft tissue on the lateral aspect of thigh, in the lower part. The soft tissue has central lucency and it is peripheral sclerotic component. I cannot see any cortical irregularity or thickening or any bony lesion in the visualized femur.
Okay.
I would. Is there any previous history of trauma? So
There's no history of trauma. Why do you ask for that?
I was thinking because it has peripheral sclerotic areas, so it could be myositis ossificans. I was thinking in terms of, but it will be more closer. But no, that is not the correct.
Okay. I'll show you the lateral radiograph and then we'll talk about the, I think. There you go. I'll magnify it for all of you. So to describe what you see.
So I can see ill-defined sclerotic soft tissue density, a soft tissue lesion in the anti-aspect of thigh. It's in the intramuscular plane, and I can also see the muscle in that region is bulky.
What's causing the bulge of the muscle?
There could be associated soft tissue density, a soft tissue lesion which might not be seen on the radiograph. So I would like to go for MRI.
Right. So your differential, what are your two differential? One you said is myositis ossificans or ossified hematoma, right? What's the second differential? What's the second differential that you are worried about? Why you want an MRI?
To look for soft tissues.
Soft tissue what?
Soft tissue component, because there is associated bulk, the muscle in that region is appearing bulky. So I would like to further investigate.
Okay. Right. Let's start with star. Okay. So that's an axial star. I'm going to scroll for all of you. Window it a bit. So that's the knee. Okay, let's go proximally. So before you describe the findings, where is the lesion?
In the muscle, in the intramuscular plane, sir.
In the intramuscular?
Intramuscular, I mean, it's in the muscle.
Which muscle is it? Or which muscle compartment is it? Let's put it that way. That's easier.
So vastus.
Yeah, vastus.
Vastus lateralis and medialis muscle.
Yeah. Well, that's the medial. So this is medialis. That's your rectus femoris. So yeah, this is lateralis, right? Okay.
Yes.
What do you see there? I mean, I'll park there. And what do you see?
So heterogeneously hyperintense lesion centered in the vastus lateralis muscle. The lesion also has associated hypointense areas, a component.
Which is what
yes,
we
sir.
have. What did we see on X-ray?
Areas of sclerosis.
Area of sclerosis or calcification or bone formation, whatever you want to call it. Because if you come here, there was this kind of a solid kind of density, right? Okay, calcified density, this thing there. And that's what you're seeing here in the surface of the lesion. Okay, I'm going to show you the T1 weighted image. And then let's see whether you can help us give some differential. So if I put the T1, plain T1 weighted image here, okay. Can you see, can you define something in the lesion? Can you define the components which make up the lesion, tissue-wise?
So, yes, sir. So the lesion is predominantly hypointense, but also has central hyperintense areas. So it could represent hemorrhage within the lesion.
Or?
Also, or could be fat.
Right. Okay. So with that two things in mind, which two kind of differentials you will put? It's not a hematoma, isn't it?
No, sir.
So a deep intramuscular large mass with ossification, with some fat next to the joint. Give me two differentials, or give me what's the generic kind of diagnosis we are thinking about here?
So although it doesn't look aggressive to me, but
okay, but what do you mean it doesn't look aggressive to you?
I mean, it's not crossing the facial planes or extending into the other compartments. It's just localized to the muscle.
Do you think it's a
there.
benign? Okay, I know. I mean, this is a talk about kind of bone lesions, but I just put it there because now you see there. I mean, you can say it's a well encapsulated large mass with ossification there, right? And there's a lot of edema next to it, right? Okay.
Yes, it could be liposarcoma.
Yeah. Okay. Good. Yeah. Yeah. Excellent. Yeah, because it's got some fatty kind of component in it. All right. So it could be undifferentiated, dedifferentiated liposarcoma. Yeah. Okay. The other thing is, I mean, it's a soft tissue sarcoma. I think that's the word I want you to kind of tell me, right? So any solid lump is a sarcoma unless proven otherwise. And the deeper it is, the more higher chances of it, right? Any fatty lump in the retroperitoneum or mediastinum kind of thing, you'll think about liposarcoma, isn't it? But yeah, I mean, in the limbs, yeah, I mean, this is a large, deep intramuscular kind of mass. Whether, I mean, it's well defined or whatever, it's got edema here, probably which he had probably blood a bit or something in it. So the history of trauma can be there, cannot be there, but this is a sarcoma. Okay, and with calcification, when you see it's got fat liposarcoma is one thing. The other is synovial sarcoma. I mean, but that again, I mean, soft tissue sarcoma next to a joint, it doesn't have to go into the joint, but it's got calcification that makes you think it could be a soft tissue sarcoma. This was biopsied; it came back as liposarcoma. All right. Okay. So not every kind of ossification next to a joint is myositis ossificans, all right? Myositis ossificans expected to have this edema. I mean, if I see that ossification there, just edema without this mass lesion, then I would think this is myositis ossificans. Okay, but this one is a sarcoma unless proven otherwise. So yeah, this was biopsied and sarcoma. Right. Okay. Great. Okay. I think we have to probably stop there, but I'm going to show you the parosteal things because let me. Yeah, not because it's a parosteal one for people who kind of haven't kind of read about it, or it's a parosteal, right? Not periosteal. Periosteal is like we've seen the one with the tibia. It's more like diaphyseal with extraosseous soft tissue. Okay, but parosteal, it's the one which is heavily calcified. If I put it, if I find it for you now, just a second. Then to get this across. It's usually at the back of the knee, right? Okay, that's a typical kind of location. But this one I'm going to show you. This is what a parosteal osseous arc looks like. This is around the elbow, though. Okay, so this is whenever you see this kind of a large stone, a rocky, hard kind of thing related at the back of a joint or something, this is what we call a parosteal osteosarcoma. And they usually have got a good prognosis because the tumor doesn't kind of, you can easily extirpate it and it doesn't usually metastasize. But usually the age is a bit more than conventional osteosarcoma. In contrast, I'm just going to show you the one, we've seen it on the tibia, but I think it's better to see it if I show you this. Oh, wait, okay, let's go. I mean, we'll be finishing, but this one, you see? Now, this one, if I show you, this is again a similar one like the one I've shown you in the tibia, but this has got, again, that saucerization, but that's that sunburst kind of periosteal reaction, all right? Okay. And then when you do an MR, it's got the same kind of that extraosseous kind of a surface kind of tumor with periosteal reaction with some kind of infiltration in the diaphysis, but location is the key. This is diaphyseal in the shaft, not in the metaphysis like the conventional osteosarcoma. If it was, let's say, if it was a 5-year-old, I would think about Ewing's or LCH, right? But in somebody who is kind of in kind of their 20 to 30s, and you think about a bone-forming tumor, then this is periosteal. This is periosteal, right? Parosteal is hard bone. All right. Okay. That's by the way. I think we have to finish there. I mean, I can keep on showing you all night, but I think that's probably going to confuse you a bit. Any burning question? I'm more than happy to answer. Otherwise, you guys can email me. Any question anybody has? We got a few minutes.
So I've opened the chat, and if there are any questions, please feel free to put up.
Well, I hope it was useful. I know it's a mixed bunch of things, but it's just a practice for you guys to just see different appearances of different tumors and to describe things.
It was excellent, Asad. Absolutely fascinating cases, very stimulating, and I'm sure everybody gained a lot. So thank you very much.
Thank you for this opportunity. So hopefully I'll probably come back with at some other point with another session and show you more.
Yeah,
cases.
so this is exactly what I wanted to ask, that in a few months' time, whenever it suits you, it will be a pleasure to have you back on the forum.
Great, my pleasure. Yeah. Inshallah, I'll let you.
Yeah, we will, and I think in the chat also they want you back.
Great. Okay. Yeah. No worries. That's fine. No worries. Yeah, I'll get in touch with Dr. Khan, and then we'll have another session probably in the next few months, inshallah. Right. Great. Okay. It's about midnight here, so I need to say good night to you all, and best of luck, and see you again.